So welcome everybody to this Emory Global Diabetes Research Center virtual seminar. My name is Shivani Patel. I'm a faculty member of the Global Health Department as well as the center. And it is my pleasure to introduce Dr. Namratha Kandula to all of you. Dr. Kandula is a professor of medicine and preventive medicine at Northwestern University. She is somebody who works at the intersection of immigration, culture, social context, and especially cardiovascular health. She is a principal investigator of the MASALA cohort study, which I am sure all of you in attendance know about. But she also runs a really important portfolio of community engaged projects and interventions to address health outcomes and prevent poor health outcomes in South Asians and working closely also with other immigrant communities. So we're going to hear about that work today in her seminar entitled Epidemiologic and Community Engaged Research to Improve Cardiometabolic Health Among U.S. South Asians from Theory to Action. So with that, I will pass the floor to Dr. Kandula. Thank you.
Thanks, Shivani, and it's nice to be here with you all today. I understand it's your graduation day at Emory, so and that you recently had an earthquake, so it sounds like a lot going on over there. But I appreciate this invitation. So I have no financial relationships to disclose, and I receive funding from the NIH. So people of South Asian background experience a high burden of cardiometabolic diseases and cardiovascular mortality. There are more than 1.9 billion people of South Asian background across the globe. They comprise close to 25% of the world's population. And whether it be in South Asia or within the diaspora in other countries where South Asians have migrated, there has been this phenomena and what's been documented as people of South Asian background, not just experiencing this high burden of cardiometabolic diseases and mortality, but also that many of these risk factors and adverse outcomes emerge at a younger age, almost a decade earlier than in other groups. And so in the United States, we did have some very early data suggesting that pattern continued with South Asians having more cardiometabolic disease and cardiovascular mortality than other race and ethnic groups in the US. But one of the challenges of studying South Asians and other Asian groups is that data are often not disaggregated. So we really had very little information about what was happening with the health of the rapidly growing South Asian community in the United States, which is one of the reasons that in 2010, with Dr. Alka Kanaya, I helped to start the Mediators of Atherosclerosis in South Asians Living in America study, or MASALA. And the goals of MASALA were to discover heart disease risk factors for South Asian Americans, to measure the early stages of heart disease to learn how it develops, and to prevent heart disease by sharing findings with researchers and community. And the individuals who enrolled in MASALA were healthy at the beginning, since one of the goals was really to understand the antecedents of clinical cardiovascular disease. And they had to be individuals who were between the ages of 40 to 79 years. One of the things about MASALA is that it has a sister study called the Multi-Ethnic Study of Atherosclerosis, and we've used many of the same measures and questionnaires and protocols so that we're able to compare the South Asians in the MASALA study to the other race and ethnic groups in the MESA study. And I'm going to show you some of the data that we have from our baseline exam in MASALA compared to MESA. So we did learn that South Asians do, in fact, have a high burden of cardiometabolic risk factors, and we're able to confirm that. And people in MASALA were recruited from two sites, Chicago and San Francisco. So if we look at South Asians compared to the other groups in the MESA study, we could see that South Asians have a very low prevalence of tobacco use, a relatively lower BMI compared to White, Black, and Hispanic Latino groups, and very low levels of physical activity. So despite the fact that South Asians in the US, because of immigration policy, are highly educated, and that's reflected in our cohort, they still had the lowest levels of physical activity compared to the MESA groups. And then a high prevalence of hypertension, 47% had hypertension, compared to these other groups, second only to the individuals who are Black in the MESA study. And then the highest prevalence of diabetes at 27%. So one of the first things we were able to do in the MASALA cohort is just really confirm the fact that South Asians do have a high burden of cardiovascular risk factors and very low levels of physical activity and a modest BMI. In addition, we conducted a food frequency questionnaire that was developed in Canada and was developed specifically to look at food items that were consumed in the South Asian diet. And this was administered to all MASALA participants. And these items were combined into 29 groups, and participants were asked about serving size. And from that, Dr. Meghna Gadgil, who's one of our junior investigators and collaborators, was able to derive different dietary patterns. One of those dietary patterns was animal proteins, in which there is more Western types of foods, as well as things like fish, pasta, pizza, meat. And then the second dietary pattern was fried snacks, sweets, and high-fat dairy, which had a lot of added fats and butter and traditional kind of South Asian butter, which is clarified butter or ghee, as well as potatoes and refined grains. Now, this was mostly a South Asian type of diet with few Western foods, but mostly consuming South Asian foods. The third pattern was fruits, vegetables, nuts, and legumes, which included a lot of fruits, legumes, as I said, vegetables, and whole grains. And so these are the three dietary patterns. What's interesting to note is these last two patterns actually included a lot of South Asian foods and were mostly vegetarian. We have 40% of individuals in MASALA are lifelong vegetarians, but that there are actually different types of vegetarian diets, and not all vegetarian diets are equal. So when we looked at how these were cross-sectionally associated with risk factors, we found that the animal protein, which had more of these Western foods, was associated with higher cholesterol, larger waist circumference and higher BMI, and increased liver fat. The fried snacks, sweets, and high-fat dairy, again, mostly a vegetarian diet, but was associated with markers of insulin resistance and lower HDL cholesterol, whereas the fruits, vegetables, nuts, and legumes was associated with lower hypertension and metabolic syndrome. And the important message, I think, here, as I said, is that not all vegetarian diets are equal, and that this information gives us a potential strategy to try to take this information and inform clinical care for the South Asian community in the US. And so additionally, we looked at this idea of how does culture influence cardiometabolic or cardiovascular risk. And in MASALA, we measured people's traditional cultural beliefs, which is the scale to look at how sort of Westernized their beliefs are or how South Asian their beliefs are. And the stronger your South Asian beliefs are, that was associated with lower levels of physical activity. And of course, the type of diet that you would consume, in that people with stronger South Asian beliefs were most likely to eat a South Asian diet with very few Western foods. And then we also saw that increasing social support was associated with more physical activity. And the longer you lived in the US, the less likely you were to consume a purely South Asian dietary pattern. And so this is evidence that there are cultural factors and social factors, as well as time in the US, which is another marker of acculturation or assimilation or integration with health behaviors, such as physical activity and diet. And so for me, my real focus was how do we translate what we're learning in this large epidemiologic cohort to translate that information and implement lifestyle prevention interventions for the South Asian community. I'm also a primary care physician, and one of the things I would often hear from patients who are of South Asian background or even from our MASALA participants is that when a patient goes to the doctor or the health professionals caring for them or the dietitian, they really don't have the right advice for someone who's of South Asian background. And so that was really important to me, is that this knowledge we're learning in MASALA doesn't just sit, in scientific journals, but is actually getting out there to improve the health of the South Asian community. And so I established with community partners the South Asian Healthy Lifestyle Initiative, or SAHELI, where our mission was to work with health systems, public health, and community partners to reduce heart disease and diabetes in South Asian Americans. And this was a multi-sectoral collaboration between academic partners and community organizations like Metropolitan Asian Family Services, which is a large CBO across the Chicago metro area that serves South Asian seniors and their families. The Public Health Department in the village of Skokie, Illinois, that has a very large South Asian population and was interested in trying to engage that population in health, as well as the Park District in that area, an important partner for physical activity. The Skokie School District, 69, where there is a large population of South Asian students, and the school uses a model of like holistic education where parental health and child health are linked to learning outcomes. And so they were really interested in partnering with us in this work to think about how can we improve the health of the community that lives in the South Asian community that lives in the Chicago metro area and in these catchments. And so one of the things that guided our approach in this multi-sectoral collaborative is the concept of collective impact. And these are the principles of practice. So the idea is that the initiatives that we were going to develop really placed a priority on equity. And what does that look like when you're working with a specific population? One thing we know is that South Asians are not all the same. It's a very heterogeneous group, and there were many people in the Chicago metro South Asian community that had limited English proficiency or lower education levels and didn't have access to healthcare. And we wanted to ensure that whatever programs that we were testing in the clinical trial context would be reaching individuals who may not speak English as their first language or have access to healthcare resources. We included community members in the work that we were doing. We recruited the multi-sectoral cross-sector partners that we thought needed to be at the table if we were going to be addressing healthy lifestyles. We use information to learn, adapt, and improve. We try to build the capacity of everyone in the collaborative in terms of leadership and recognizing the strengths that they are each bringing to the work that we're doing, the research that we're trying to accomplish. And we focus on programs and system strategies in addition to individual behavior change. And I'll give some examples of how we did that, and then build a culture that fosters relationship, trust, and respect across our participants, and then really try to customize for the local context, which would be the Chicago metro area or the neighborhood that our participants are coming from. We didn't really talk about how we're going to do questions, but I guess feel free to put them in the chat and we can answer them at the end or write them down so that we could get to them at the end. And so the framework that I use in terms of how we adapt evidence to the social and cultural context of a community is a mixed methods approach or a mixed methods framework, where we started with qualitative interviews to understand the community's values, beliefs, and norms, and the meaning behind diet, physical activity, and health. We elicited people's explanatory models, like why do they think that people in the South Asian community have such a high burden of cardiometabolic diseases, or why does somebody develop diabetes? We try to understand their social and community context. This was followed by quantitative surveys where we looked at knowledge, beliefs, and attitudes, try to assess barriers and facilitators to behavior change, as well as people's social networks as a lever for change. And then these principles of community engagement, where we take what we learn from this mixed methods approach And we integrate it with community partners with what we know about the evidence on cardiovascular disease prevention. We build on social and community level strengths, not just thinking about weaknesses or risks or barriers. And then it's an iterative process that we engage in with our community partners. And then throughout this process, it's important to approach it with humility, which is a commitment to self-awareness, self-evaluation, and critique, and trying to do things better and really listen to our partners, and not assuming that we as the academics hold all the knowledge in terms of how we're going to improve the health of a community. And so when we did that, we asked people, like, what do you think are the major diseases affecting your community? And it was really interesting because the very first thing that came out was the stress of immigration, and then mental health, like depression, that often occurs because of so many of those stressors and the loss of social support when somebody immigrates to the United States. And then that was followed by cardiometabolic conditions, which was positive because it meant that the community wanted to certainly work on these things, but just recognizing that they had more of this holistic idea of what is health, and that stress and depression would be an important part of these other cardiometabolic outcomes. And people thought that stress was the number one reason that people in our community were at risk for developing heart disease or having a heart attack. And many people talked about stress reduction as central to that, with a lot fewer people talking about actually controlling cardiovascular risk factors or being more physically active. So we see an opportunity here for integrating the community's beliefs with also talking about these other risk factors and behavioral factors. And so these are this is an example of what we learned when we really tried to go more deeply into people's explanatory models and ask people, what do you think causes heart disease? And as I said, it was, the first domain really was that holistic sort of psychological aspect, psychological and social. Tension, they call it worrying. If somebody worries a lot and is very tense, then they will have heart disease. And then the next most common domain was the behavioral, this idea that diet, that if you eat too much garbage or things with cholesterol or carbohydrates, that can lead to heart disease. And then physical factors or clinical or biological, that if your cholesterol is high in your blood, that might be one of the reasons that people have a heart attack. And then this one I always think is funny, that this idea that heart attacks happen very suddenly by an adverse event. And this example that I've seen it 3 or 4 times, if you watch a cricket game and get the favorite player out, the person has a heart attack right there and then and just dies. It's just shock. And then spiritual, which was the fifth domain, which is people think about what will happen, forget about what might happen. God will take care of everything. Everybody has to die one day. So that's kind of more of a fatalism or a religious kind of handing that over to a higher power. And so, using this information, we realize we really need to take a holistic approach to any kind of behavioral intervention and address all of these domains and not just say diet or lifestyle or clinical risk factors. And then importantly, there's also the intersection of other social categories, such as gender, with immigration and culture. And we specifically wanted to understand, because we saw that women in the MASALA cohort had even lower levels of physical activity than men. So we really wanted to understand how immigration and culture and gender might be intersecting to affect physical activity behaviors. And so what we learned is there are things such as family norms, like I can't say in front of my relatives that I'm going to go exercise, or there are these gender constraints on girls and women in terms of what you're allowed to do in terms of physical activity in public spaces. And there were these beliefs that you don't really have to exercise if you're thin or underweight. You don't have to go to the gym. It's kind of a waste of your time. And then there were also positive things, such as family and social support, which was I really do exercise or I'm physically active because I'm working with I want to play with my children. I want to be active with my family. And then this recognition by some members of our community that women really do need social support, and thinking about like, who is that important person? And people often identify the spouse, like my wife won't go and start working out by herself, and that it might be really important to have spousal support. And this gets to the idea that a lot of health behaviors are not about the individual, but they really are embedded in family systems and in a social context. And so taking that mixed methods information, we thought about, how do we develop or adapt an evidence-based lifestyle intervention both to the surface structures or the visible aspects of culture, such as making sure that the intervention takes into account the language people speak, the types of foods they're eating, if you're creating scenarios or case studies that involves things that would be familiar to people who are South Asian in terms of the types of characters or the names you would use. And what we know is that when you adapt an intervention for the surface structures of culture, that increases audience receptivity, it gets people to listen. But what's also really important is that you think about the deeper structures of culture, and those are things like beliefs and norms and values, explanatory models. What is the meaning of the behavior? What is the context in which that behavior is occurring? And you have to do both of these things. The intervention also has to address these deeper structures because that increases the salience of the message and is more likely to get people to act on the information that you're giving them. So when we thought about adapting diet and physical activity and lifestyle interventions that are well established, like the DPP or the DASH diet or the Premier hypertension interventions, we tried to adapt it both to surface and deep structures of South Asian culture. And so adapting evidence-based lifestyle interventions, the hypothesis that we entered the research that I'm going to now describe to you was that adapting evidence-based lifestyle interventions to cultural and social context can increase the reach and effectiveness of lifestyle prevention programs for immigrant communities. And the key cultural factors or some of those deeper beliefs that we adapted our intervention to is this idea of family being very important and being more important than perhaps an individual's behaviors, and that anything you do should benefit your family. The other is this idea of allocentrism, which is that sort of community norms and community the community is more important than the individual, and recognizing that that can act as both a risk factor, but also a positive place to get social support. And then the gender norms that I described, the idea of respect and power distance, like how do people interact with each other in terms of authority and who gets to make decisions about what a family might eat and who gets to take time out for exercise. People's illness beliefs, again, this idea that stress is a really important factor in terms of developing cardiometabolic conditions. And then people's cultural identity. And what that means is recognizing that the food you eat or the behaviors that you might enact are really linked to your cultural identity. And that if you're going to ask people to change those behaviors, you might actually be coming up against cultural identity as either a barrier or, again, a positive thing. And how do you kind of integrate those concepts so that people feel that they're not giving up cultural identity when you're asking them to change a health behavior? And so we tested this hypothesis in 2 community-based type 1 hybrid trials. A type 1 hybrid trial means that you're looking at the effectiveness of an intervention, but you're also collecting preliminary data on implementation strategies. And the SAHELI randomized clinical trial is the one that I'll be talking about today, and that is a stress management, diet, and physical activity intervention that was recently published last fall. And then I'll also be, we also did this work in a clinical trial that we have yet to publish on, and so I won't be presenting that data, but have recently finished, which is South Asians Active Together, which is a multi-level physical activity intervention trial for South Asian mothers and daughters. And SAHELI is the trial I'll be talking about next. So the SAHELI trial, the question that we were trying to answer is, does a culturally adapted group-based lifestyle intervention improve cardiovascular risk factors more effectively than written health education materials among South Asian adults in the US? And our primary outcomes were differences between the intervention and control groups in the change in weight, systolic blood pressure, diastolic blood pressure, total cholesterol, and hemoglobin A1C from baseline to 12 months. So it's hard to believe everything we lived through in the past few years, but one of the things that happened right after we launched, or a few years after we launched the SAHELI trial, which started in March 2018, So we started this as an in-person lifestyle intervention with follow-up assessments, of course, that were in person at 6 and 12 months. And so 2 years into our study, the COVID-19 public health emergency began, and we had to adapt, obviously, and we had to shift our intervention to being delivered virtually. And then conducting follow-up assessments, there was, of course, some missing data, especially times when the Chicagoland or the state of Illinois was in public health lockdown. And so, we had to deal with issues of how do you collect cardiometabolic risk factors remotely, and how do you deal with missing data? But we were able to persevere and achieve our goals, and the study ended in February of 2023. And so who participated in SAHELI? Again, this was only conducted in the Chicago metro area. You had to be of self-reported South Asian background between the ages of 18 to 64 years. You had to have risk factors for heart disease, like a high weight, high or body mass index, high blood sugar, high blood pressure, or high cholesterol. But this is a prevention study, so people who'd had a heart attack or stroke were excluded. And 549 people joined the study. We had 318 women and 231 men. The majority of them were of Indian origin, 14% were of Pakistani origin, and 7% were other South Asian. Like 98% of our participants were immigrants, as opposed to being born in the US. On average, they were 49 years old, and we were able to recruit over a quarter of our population that had less than a high school education. And the individuals recruited into our study were recruited through those partners that I described, through this multi-sectoral partnership. So they were recruited through health systems, community-based organizations, and the school district parents of the school district that we were working through, as well as a lot of different community outreach fairs at religious organizations and other CBOs. So after enrolling in the study and meeting the inclusion criteria, people were randomized either into the intervention, which was group classes once a week for 16 weeks, or to a control arm where they were mailed heart disease prevention information each month. And what was this group-based lifestyle intervention? So the SAHELI intervention was based again on evidence that we have from other populations. It included 16 weeks of group classes. It was delivered in community settings by lay health educators who were trained in lifestyle counseling and behavior change. It was delivered in 4 different languages: English, Gujarati, Hindi, and Urdu, depending on the composition of the class and their preferences. And so we would try to get groups together based on their language preference. And it really focused on helping participants improve their diet, their exercise, their stress, their weight, social support, and confidence around enacting behavior change. And individuals were coached around setting goals and staying motivated by the lay health educators. People also received Fitbits and were asked to complete food logs as part of the intervention. The control groups received monthly education pamphlets either through the mail or email, such as, how do you keep your heart healthy? How do you manage your weight? And this group received that actually over the entire 12-month period, once a month. And this is our participant enrollment flowchart. So we screened 881 individuals. And you can see that 331 were excluded you can see some of the exclusion criteria here. So eventually 549 individuals were randomized. And you can kind of see how we did with our completed follow-up at 6 months, 209 out of 274 in the intervention group. And then at 12 months, 208 individuals, we had complete follow-up. And this was an intention to treat analysis, so everybody was included, and we had to, of course, impute data that might have been missing. And we had a similar amount in terms of completing follow-up and complete data in terms of individuals who were allocated to the control arm. This table describes the baseline health characteristics by treatment group, and in here you have the group lifestyle intervention and the health education materials. And so you can see that people would be meeting the criteria for being obese by the Asian BMI cut point. So on average, the BMI of participants in SAHELI was 29, and there were really no differences in terms of the intervention and control arm in terms of these baseline health characteristics. But what I do want to point out is that upon enrollment, people's blood pressure was actually normal. It was, 125 in both arms systolic and 79 diastolic. And similarly with their cholesterol. But the two main risk factors that people were eligible for our study, which is not surprising, is their body mass index and their hemoglobin A1C. So people were in the pre-diabetes range. And of course, people may have had high blood pressure, but it was clearly well treated, at baseline. And then people were, on average, we used accelerometers to measure people's physical activity. They were getting about 23 minutes of physical activity, moderate vigorous physical activity per day. So they were relatively active, as opposed to being, sedentary, even at baseline. And so this just gets to the idea that often people who you recruit into trials might be slightly healthier than the average population. And this table describes the primary outcomes from the SAHELI trial. Right in this column, you have your outcomes of weight, blood pressure, cholesterol, and hemoglobin A1C. You have the 12-month estimates of each group with the change from baseline. But the real, primary outcome is what was the mean treatment difference in terms of these risk factors at 12 months. And so what you can see here is that there were no significant treatment differences between the intervention arm and the control arm at 12 months. There were very small differences in terms of weight, blood pressure, cholesterol, and hemoglobin A1C, and none of them, and all of those crossed the 95% confidence interval. In terms of secondary outcomes, which were pre-specified, these include diet quality, which was self-reported, moderate vigorous physical activity, which was measured both with accelerometry and self-report, as well as self-efficacy, or the confidence to make physical activity or to have healthy physical activity and dietary behaviors. And so again, small mean treatment differences, but and these were corrected for the fact that we have multiple outcomes. But we did see that the intervention arm did have greater improvement in their dietary quality. And when we decompose diet quality, we can see that it actually does align with the curriculum that we delivered, but the intervention arm had greater improvement than the control arm. And while the actigraph, which was the accelerometer, did not show improvements in moderate vigorous physical activity, in terms of self-report, the intervention arm did report more physical activity than the control arm and a greater change in moderate vigorous physical activity. We also see small improvements in self-efficacy of the intervention arm compared to the control arm, both physical activity self-efficacy and dietary physical self-efficacy. So some small signals related to behavioral outcomes and confidence. And you might ask, what was the attendance in the 16-week intervention? And we also were really interested to see, for the people who were attending before the COVID pandemic, and then those who got the virtual delivery of the intervention, was there a difference in intervention attendance? And what you can kind of see here, which is described in other 16-week behavior change interventions, is that attendance does drop off over time, but it was actually quite similar pre-COVID and in the COVID cohort, speaking to the fact that virtual delivery may actually improve attendance because it does allow people to attend the group, whereas if you have to come in person, other barriers might get in the way. And what you can see here is the number of classes that intervention participants attended overall. And what you can see is that 43% of individuals in the intervention arm attended at least 80% of the classes. And that 80% cut point is something that has been well described, that if people receive 80% of an intervention, it's going to be more, that's sort of the active, that's the dose that you need to see behavior change. you can see that less than half of our participants were able to achieve that. But again, there is a group that didn't attend any of the intervention classes, and then it's sort of this distribution here. So, of course, the quantitative outcomes are the primary outcomes, and that really does, and the secondary outcomes, and that really was what we were looking at. But we also collected data on implementation as well as participant-centered qualitative information. And these are some of the things that we learned that the participants in the intervention arm felt was a benefit of being part of the study and the lifestyle intervention. And one of the things that we think is really important that comes out of this is that participants really shared a lot of what they did with their family members, and that's not something that you're necessarily going to be able to measure in terms of a quantitative clinical trial effectiveness outcomes. So participants said, I don't recommend my kids to eat a lot of packaged foods after participating. I recommend her to eat fruits and veggies. That's what I'm doing. I'm bringing this change into my home. Another participant talks about eating more vegetables before they eat other carbohydrates and their food. And so it's helped increasing the amount of fresh fruits and vegetables they were eating helps cut down on other things. People talked about feeling more confident and seeing role models in their classes and being able to look after themselves. And that tracks with our improvements in self-efficacy. And then people talked a lot about just that group support that they got by participating in SAHELI was really helpful to them by making friendships. You start looking forward to being part of the group. And then even during COVID-19, that people would do conference calls together and talk about how many steps they'd gotten on their Fitbit. And so giving people that kind of social support that we know can be challenging for many immigrant communities was another part of the SAHELI intervention that was a benefit. And then when we did sort of this implementation evaluation, we surveyed our partners quantitatively and qualitatively, both on implementation factors and sustainability. And again, this is from the perspective of our partners, so the CBOs, the public health department, the school district, and the health systems we worked with. And so some of the things that facilitated the implementation of SAHELI and potentially could act in terms of improved sustainability is the partners said that they've really felt that the intervention and the work, the benefit, the need, and the fit of the intervention was very strong with the population that we were trying to serve, which was the South Asian population. And that there was also a strong fit with the organizational mission, the goal, and the activities that they had for themselves as an organization. And that they were able to tap into those networks within the South Asian population and also with each other to really enhance the engagement of South Asians in the SAHELI study. So these are some of the facilitators, and I think this kind of information is really important when we think about how do we implement lifestyle behavior change interventions with multi-sectoral partners. In terms of some of the barriers, not surprisingly, in terms of thinking about implementation and future sustainability, one of the biggest issues that comes up is lack of funding or staff to continue this work once the grant might end. In addition, competing priorities for our public health department and our health system, especially during the COVID pandemic, made it a challenge to think about how would they continue the work that we were doing. And then the other thing that came up that I thought was interesting is this idea of like, how could we offer a program selectively just for the South Asian community without including other populations? So that the organizations really wanted us to start thinking about how do we take what we're learning from SAHELI or this type of work that's very focused on one population and ensure that we can scale it out to other groups and benefit other groups that they work with. And in addition, I think there are other important positive outcomes from the SAHELI trial and the community engaged partnerships is that we were able to enroll immigrant participants and individuals with limited English proficiency and low education in a 12-month cardiovascular disease prevention trial. This really raises the bar for inclusion in terms of clinical trials. These individuals are often excluded from participating in clinical trials, and there's SAHELI really was the first large-scale lifestyle intervention for South Asians in the US. And so that just tells you that people of South Asian background are often not represented. And then these groups within the South Asian community are often not able to participate. We also identified the key implementation strategies to address barriers to accessing evidence-based lifestyle modification for the South Asian community, such as the location that you're going to have this intervention, the fact that you are going to have South Asian educators who can speak multiple languages to deliver this type of intervention, and also trying to provide that social support and that group cohesion seemed to be something that helped people overcome barriers to behavior change. In addition, an important outcome is not just completing this trial as an academic and getting my next grant or publication, but that our partners and our community advisory board really felt that we enhanced their capacity to raise awareness and meet the needs of the South Asian communities that they were serving. And so how do we see that happen? I mean, I talk about from theory to action to systems level change. So how did we see the capacity of our community partners actually improve over time? And this is an example from our school district partner where they were creating a healthy, fresh market for their families, especially families that were experiencing food insecurity. And so as part of that group, they really did a lot deeper work to understand what are the types of foods that families are eating and would want to access in a fresh market pantry, which is, sort of like a on-site school food pantry where families could pick up perishable and non-perishable goods or get a grocery box delivered to their home. And so not only did they really try to tailor those types of foods to the South Asian families that they were serving, but recognizing that there are a lot of different cultural groups in the school and that it would be really important to think about that as they planned their fresh market. And then our partner at the Skokie Park District also started to offer a women's only exercise class that many women were interested in, not just South Asian women, but that was something that might be important to be able to engage more South Asian women in physical activity. And then this past year, they had a large Eid celebration, which was really lovely to see. And they said this was really grew out of our work and that desire to engage the South Asian community in all the physical activity opportunities that exist at the Skokie Park District. And then our public health department partner during COVID really used a lot of what they've been learning through the work we've been doing to ensure that materials about COVID vaccine and public health prevention measures were translated into appropriate languages. And we actually helped them do a lot of that work. And then also ensuring that the vaccine information that we were disseminating was culturally appropriate and was reaching South Asian and other immigrant populations. And so then I just wanted to also share that this is a picture from the SAHELI partnership receiving the Public Health Partners in Excellence Award from the Village of Skokie in 2023. And that is an award that is given to an organization or a partnership that is really thought to have improved the lives of the citizens of the Skokie area. And I think it's just really nice when, as a researcher, you can kind of see some of the impact of your work much more rapidly than it often feels when you're doing sort of these really long-term studies and you're not really sure if anybody's ever going to benefit from them. So in terms of conclusions, the SAHELI intervention did not demonstrate clinical effectiveness, but through this work, we really did identify key community implementation strategies to enhance equitable reach of evidence for immigrant communities, like the trusted community setting, health coaches from the South Asian community, and intervention delivery in multiple languages, as well as the importance of group social support. And recognizing that in terms of next step, what are we going to think about next as a partnership, that we probably really need layered approaches. Specifically, how are we going to think beyond just the individual level of behavior change, but perhaps really thinking about how do we activate supportive social ties? Do we need to increase the intervention intensity or adherence? How do we partner with clinical healthcare systems to potentially add clinical interventions that might be needed? And then work with organizations that can influence policy to address barriers to behavior change and cardiometabolic health behaviors at multiple levels of influence. So just some of the small and big things that are on my mind as I think about the next steps for this work. And I just want to thank our partners, our participants, and everybody who has been involved in this important work. Thank you.
Thank you. That was a wonderful seminar. I believe Wendy Gill has offered to moderate our questions, but as people are coming up with their questions, I thought I'll take the liberty of asking the first one. So really enjoyed your presentation, and also you're outlining the journey from the observational work to the intervention that you've created. And it's quite actually an ambitious agenda you have, or rather like themes that you've laid out in your final slide about the clinical add-ons as well as the social network add-ons. And I was wondering, in terms of kind of prioritizing those next steps, where you see the role of some of the more newer pharmacological agents, especially for metabolic health, kind of being integrated potentially with behavioral interventions, and if that is a way you're approaching it. I mean, those of us working in diabetes have been somewhat astounded by everything that's happening with the diabetes subtyping, and the idea that maybe physical activity and diet interventions alone won't work for some people, and especially the people with the type of diabetes that seems to be more prevalent in South Asians. So curious about your thoughts there about integration.
Yeah, so thanks for that question. I think, the integration is really important piece of this. Is it the piece that necessarily I want to take on? I'm not sure, because you're asking about prioritization. But I think I agree. We can't do this work without very close clinical community integration. I do this work recognizing that a lot of people don't have access to those medications or to healthcare, to clinical care. And so it's important for me to still really think about what are the levers we can use within community settings to promote healthy lifestyles, to get people access to care, and to the types of insurance that they may need. And so for me, the priority may stay in the community setting, and thinking about how do we create that linkage that if people do have access to those drugs, it can be helpful. With regards to just like our lifestyle interventions, the right interventions for the types of diabetes that South Asians have. I mean, from MASALA, there were sort of those different subtypes of diabetes, and the one that was most prevalent was the abnormality in fasting plasma glucose, which suggests beta cell failure. And so, yeah, diet and physical activity and telling people to lose weight may not necessarily achieve protection of those things. And so, yeah, again, clinical pharmacological approaches would be really important for the South Asian population. But one could also argue so might like a more of a strength training approach and building muscle mass. So again, and people always want to know, like, how do I optimize my diet? How do I optimize my stress levels? I think we have to come back to also remembering what the community said. I know this is really long, but in like thinking through this all is that they think stress is like the number one factor that we need to be addressing for them, right? And like these medications aren't necessarily going to get at that. So how do we build that confidence, that group support, help people also address their stress levels while we're offering them clinical interventions?
Thank you. Thanks.
Go ahead, Megan. Okay, thanks. Hi, Nami. Thanks. It was a really great talk, and nice to see all this work come to fruition. I had two questions for you, if you don't mind. My first was, and this is really based on some of the similar work that we do in Atlanta with Nadia Islam's team. I was really surprised and interested to see, because you guys have kind of pre-COVID and during COVID data around intervention engagement. And you mentioned that there really wasn't a difference in attendance pre-COVID and during COVID. And it's hard to know for sure, because like for us, when we did our pilot study in Atlanta for DREAM, it was all during COVID, so everything was telehealth. And the feedback we've gotten from our community health workers is that the telehealth piece was incredibly helpful to keep people engaged, because in Atlanta, at least, transportation is a major barrier. And the cost of coming somewhere in person is very challenging for a lot of people from the South Asian community who might rely on rides, not drive themselves. And I was interested to see if you guys had looked at anything like that or gotten feedback from the participants themselves around the telehealth piece, and how much engagement they had, or their kind of satisfaction or receptiveness or acceptability with the telehealth shift is my first question.
Yeah, so I think, attendance is one thing, but measuring, how effective was the intervention delivered virtually versus like with a group when you're with people. I mean, I think people lost out a little bit on what we heard is people lost out a little bit on that group interaction and the ability to form stronger ties with the other people in their group virtually. And so much of SAHELI, when we had planned it, was about that group interaction and creating social support. So I think people did lose out on that. We also really tried to have the sites that people would go to receive the intervention be within like a 5-mile radius of their home, so quite close. I mean, 5 miles is still can take you a while to travel 5 miles depending on where it is. But we did try to help people really like by delivering it within their community or at a close community site. But clearly, I think we don't fully know the mix of virtual and in-person that might be effective. So maybe it's that you get together for the first few sessions in person, and then you get together virtually, and then come back in together at some point. So I think that would be interesting just to kind of understand like what is the ideal mix of virtual versus in-person. But we did look at, we did a sensitivity analysis to understand if COVID attenuated the effect of the intervention. It does seem like COVID attenuated the effect of the intervention, but like, again, we don't know exactly why, right? Was it because of everything going on because of the pandemic, or was it because of the intervention being delivered virtually wasn't as effective? And obviously we weren't powered to answer that.
My second question was about your end of study and follow-up time points, because I think you mentioned kind of your baseline is that like most of the participants had some metabolic syndrome, but when they're starting out an A1C of 6%, there's not a lot of maybe room for clinically significant improvement, for example. I'm curious if you guys have thought about or are able to follow these participants for more than just like the end of study period to look at kind of sustained change, or if that's in the works or planned.
Yeah, I mean, it wasn't, but that would probably be important. Like, could we do a further outcome study? But no, that isn't something that's planned. But I agree that the timeline on which we measure prevention probably needs to be a lot longer, right? Is like, how are you really going to understand the benefit of something at 12 months? Because it really is about the long term.
Yeah.
Thanks. Nice to
Thanks.
see you.